So today we're going to continue talking about hypersensitivity reactions, aka allergy. There are 4 types of hypersensitivity reactions. We talked about type 1 and type 2 last time. So a type 1 hypersensitivity reaction, if you remember, involves IgE antibodies and activates mast cells and leads to an immediate type response. A type 2 hypersensitivity response, which we also talked about last time, we don't really care about its timing, but we do care about the fact that it has IgM or IgG antibodies causing the main effects. And the antigen in the case of a type 2 is a cell surface antigen. And generally the cell bearing that antigen is going to get killed. So we went through those 2 types of hypersensitivity last time. And we're going to start off today with the type 3. So type 3 also includes antibodies, just like types 1 and 2. And to be honest with you, a lot of people sometimes confuse type 2 and type 3 a little bit. So I want to point out what's super key here about the type 3. In a type 3 hypersensitivity reaction, we have immune complexes that are causing the problem. And really what's key here is it's still antibody, it's still IgG or IgM. The difference is that the antigen is a secreted soluble protein. It's not on the surface of a cell. So if you look back to the type 2, the antigen, which is here, the green oval, was on the surface of a cell. Here, that green oval is free. And that's the big difference between type 2 and type 3. Nothing can get, we're not going to kill a cell here because there's no cell to get killed. The big problem is that we have immune complexes where there are multiple antigens and multiple antibodies coming together. And those immune complexes are what cause our problems. And so type 3 hypersensitivity is sometimes also known as immune complex disease. So what you can see with immune complexes is that they are dependent on the concentration of antigen and on the concentration of antibody. So on the left, you can see a situation where we have a lot of antigen, a small amount of antibody, and you can see that each antibody binds to a couple antigens. We don't really see any complex formation. No antibody is bound to the same antigen. No antigen is bound to the same antibody. It's just all separate. If we have a lot of antibody, a little antigen, you can see that we get maybe a few situations where multiple antibodies are with one antigen, but largely everything again is separate. However, if we have the just right concentration, because again, Goldilocks and the 3 bears is the most important thing to know in immunology, you can see that we get antibodies and antigens binding one to another, and we get these larger, higher order protein complexes. And so again, if we have very little antigen, we mostly see free antigen and no complexes. We have very high antibody, we see lots of antibody, we see no immune complexes. But there is sort of this period right in the middle where there's just the right amount of antigen, just the right amount of antibody, and we can have some type of immune complex. And here it's showing it where your antigen degrading over time, your antibodies being induced over time, and that there might be some brief period of time where you might see immune complex formation. If we see immune complex formation, those immune complexes can start to cause problems. So here you can see immune complex formation that may actually lead to inflammation. We can see changes in mast cells, or we can see sort of those FC receptors being bound by other cell types, complement binding, other cell types being activated. And in the end, we get local inflammation in the area where those immune complexes are deposited. And so that is not pleasant, but it's not sort of a huge, terrible problem. However, those immune complexes can also do things like deposit in small blood vessels and actually block those small blood vessels, so we can't have blood flow through them. And so if we start to have deposition in the blood vessel, we're actually going to have stop blood flow, potentially through the capillary. We also might see those immune complexes that are on the blood vessel wall recruiting inflammatory cells like neutrophils and starting to attack the vessel wall so that we have inflammation at the blood vessel or vasculitis. So we're going to have blocked vessels as well as inflammation. You could imagine the same kind of thing happening in some of the small tubes in the respiratory tract and thus blocking lung function and blocking breathing. You could also imagine those immune complexes depositing in things like the small tubules in the kidney, thus blocking flow of materials through the kidney and leading to kidney inflammation. And so any of these places where those immune complexes can deposit can lead to actually blockage or inflammation of that particular organ. Just like with our other types of hypersensitivity responses, there is one really famous example of a type 3 hypersensitivity response. This famous example of a type 3 hypersensitivity response happens when someone gets passive antibody therapy. So if you remember, one thing that we can do to deal with certain types of infections or other agents is that we can actually use pre-formed antibodies and inject them into an individual. So this is called passive antibody therapy because this individual is not making their own antibodies actively. They're just receiving antibodies somebody else made. And those antibodies can lead to recovery. So for example, if you were to get rabies, one of the things that they would do is that they would give you rabies antibodies. They'd give you rabies immunoglobulin. And so in theory, those rabies antibodies could neutralize the rabies virus and block you from getting sick. Now, if you imagine this, what would happen if you got rabies again? Let's say you got rabies, we treated you with passive antibody therapy, you lived, you were all good. What happens if you get rabies again? Yeah, Emily?
You have to be treated for it again?
You have to be treated again because here we haven't induced a B cell response. We've given you some antibodies. They're proteins with a half-life. They're going to last for a little while and then they're going to be degraded. And you never induced your own B cell response. So you're not going to have started to make any sort of B cell response. And so you could imagine, that you got rabies twice, and then I would be like, what are you doing? And you can see some other examples of things where you might get passive antibody therapy as a treatment here. So you can see tetanus, you can see snake bites, you can see measles, you can see botulism, you can see black widow spider bite. And so we are going to spend a second thinking about that black widow spider bite. So let's imagine that you got a black widow spider bite and you got treated with passive antibody therapy. What specifically is in that syringe that you're treated with, according to this slide? Okay, yes, antibodies. Yeah, Mark.
I was going to say antibodies from the individual.
Mm-hmm.
Probably some sort of serum.
Okay, yep, antibodies from the immune individual and some sort of serum. But we've got to think for a second, who is the immune individual in this case? It's a horse. So in this case, you're getting some antibodies that were made in a horse, from a previously immunized horse. Horses are big. and thus you can get a lot of antibodies from them. You can see horses on a lot of these. So we're going to black widow spider bite. We're going to treat you with antibodies against the black widow spider venom that were made in a horse. Can you imagine any problems with this scheme? Yes. Yeah, horse antibodies are foreign. You are not a horse. And so the horse antibody is a foreign protein. In theory, you could make an immune response against the horse antibody. You get a black widow spider bite, you get this passive antibody therapy with horse antivenom. Are you very worried about your anti-horse immune response? No. You want to not die of this spider bite? You really do not care about your anti-horse immune response. Now let's imagine you get another black widow spider bite. What are you doing? But anyway, but you get another black widow spider bite. Now what's the problem? Yeah. Yeah, you have started to make an immune response to horse antibodies. And so now we might have problems if we try to treat you with horse antibodies again. You've made an anti-horse antibody response. I don't know if they have them made in another animal. I am not an expert in black widow spider bite treatment. And so when patients are treated with passive antibody therapy, sometimes they end up with a disease known as serum sickness. Now, if we are treating with antibodies from an immune individual. Historically, you would treat with serum, which is why it was called serum sickness. So the idea here is that we are injecting in antibodies. We're injecting in horse antibodies. And in fact, they are an antigen. We inject them in, you have a really big response. And then those antibodies are degraded because there's a half-life. But over time, you are also developing an immune response against those horse antibodies. There is some period of time where you might have the horse antibodies at just the right concentration and your antibodies at just the right concentration to induce immune complexes. This is possible the first time you get passive antibody therapy, though it is, of course, much more likely to happen the second time through. So don't get bit by a black widow spider twice. And in that time where you have just the right amount of antigen and just the right amount of antibody, immune complexes can form, and they can lead to generalized inflammation, so you'll start to have a fever. They may deposit in the vessels, and so you might get vasculitis. They may deposit in the kidneys, and you may end up with nephritis. And they may deposit in the joints so that you get arthritis. And so all of these things can be a side effect of that introduction of this antigen. This is the most famous example of a type 3 hypersensitivity response, though it is not the only. You could imagine a variety of blood-borne antigens potentially leading to this type of phenomenon. Yep, Vanessa.
What is nephritis?
Hmm?
What is nephritis?
Nephritis is kidney disease. And so I apologize for the slight grossness on the next slide. In the grand scheme of gross slides I got, this isn't that bad. But these are examples of individuals with serum sickness. And so again, we can, if the antigen is in the vasculature, we can actually see immune complexes hitting the blood vessel walls and leading to vasculitis, in the kidneys leading to nephritis, in joint spaces leading to arthritis. We can see situations where we have people who are getting a rash because they have those immune complexes depositing under the skin, and both of these pictures are showing you immune complex deposition under the skin, leading to an inflammatory response under the skin. There are also is a disease called farmer's lung, where sometimes there'll be an inhalation of certain types of antigens, and you'll see immune complexes depositing in the alveoli or at the alveolar capillary interface, causing breathing issues. And so this is sort of the classic type 3 hypersensitivity reaction. So the fourth awesome type of hypersensitivity reactions is called type 4. Type 4 hypersensitivity reactions are unique compared to the other ones we've talked about for a couple of different reasons. First of all, a type 4 hypersensitivity reaction, as you'll see going forward, is largely dependent on T cell responses. The other three that we talked about were largely dependent on antibody responses. So this is the T cell one. In fact, sometimes when I think about a type 4 hypersensitivity response, I think about it as just being a fancy name for a Th1, because it's going to look very much like a just plain old Th1 response. The other thing that's really important about a type 4 hypersensitivity response is that the timing of the symptoms are also important here. So with type 1, we talked about the immediate type hypersensitivity response. With a type 4, we refer to it as a delayed type hypersensitivity response, or a DTH. So if you ever hear immunologists talk about DTH responses, this is what they mean. And with a DTH response, you tend to see a response within 72 to 96 hours after exposure to antigen. And you will see sort of the details of this as we go through the response. There are lots of different types of DTH responses. They include some responses to some microbes. We're actually going to talk a little bit about one of those. They are also, the poison ivy response is a DTH. And if you have a nickel allergy, if any of you get really weird red marks when you wear cheap jewelry, that's a nickel allergy, and it's also a DTH response. So these are relatively sort of standard or famous responses. If you think about a type 1 hypersensitivity response, that type 1 hypersensitivity response I told you was immediate, but then I put a little asterisk by the immediate, because I said it's immediate the second time. There was this response you had to have the first time you responded to the antigen that was called the sensitization response, and then the second and subsequent times you actually had an immediate response. Similarly, with a type 4 hypersensitivity response, we have two phases of the response. We have a sensitization phase and an effector phase. And so similarly, you don't see a DTH response until the second time you're exposed to the antigen. The first time, you really don't see this at all. And so in the sensitization phase, you are exposed to the antigen, that antigen is presented to T cells, and you induce a Th1 response. So we're going to have some IL-12 that is going to induce Th1 cell polarization. We're going to see interferon gamma responses, all that good stuff. And so the first time you see antigen, basically you're just turning on the Th1 response. The next time that you see antigen, you already have Th1 cells present and ready to respond. These are now sort of those activated memory cells that respond with a much lower threshold. They respond much faster. They respond much stronger. And so when you see that response, suddenly you're going to see a whole lot of cytokine secretion and a whole lot of some type of inflammatory response. And so what you will see happen is that second time through, you will be exposed to antigen. that antigen will go to the lymph node, will stimulate T cells, and those T cells will head straight back to the site of injury and start to induce vasodilation, start to activate macrophages, start to do all of the things that lead to a classic inflammatory response. That trafficking of the antigen to lymph node, T cell activation, and T cell return to the site of antigen exposure itself takes around 72 hours. And so that's why we usually think of this as being about a 72-hour process. Realize this is happening because it's the T cell's second time seeing antigen. The T cells were seeing antigen for the first time. This would not be a 72-hour thing. This would be a much longer thing. And so you can see the same thing actually on this early slide where I told you about the DTH response, where here you can see if someone is exposed to nickel, if they already have T cells responsive to nickel already in their lymph node, the nickel goes to the lymph node, T cells respond, and they go straight back to that area about 72 days later and induce some type of a reaction that we will see. And so this is that delayed type hypersensitivity response. Delayed because it's like 72 hours after exposure to the antigen. And we will start to see swelling and other types of symptoms. Yep, Mark?
So does this like only happen with like contact, like skin contact, or can you get type 4 hypersensitivity response through like the digestive tract?
Every example that I can think of, whenever we do experiments with it, we do experiments with skin. We always do them as skin experiments. I can think of one example where the antigen is respiratory. I can't think of any GI examples. I'm not going to tell you that it could never happen, but generally when people study it, you always study it in skin. Is the best I can give you. And so, in fact, as a result, sometimes people even talk about this in terms of contact and contact hypersensitivity. And so this is one of the examples of a type 4 hypersensitivity response that I want to show you. And this is actually a poison ivy response. This is poison ivy. It has this compound in it, which you can see here, the urushiol. When you're exposed to that compound, it actually goes in and reacts with a self-protein, modifying that self-protein. So your self-protein is now different than it normally was. See, it has green dots on it. As a result, this is now a novel antigen that your immune system has never seen before. And so this novel antigen will be presented by antigen-presenting cells and will lead to a Th1 response. And those T cells can eventually go back to the original place where our poison ivy was contacted, and we'll see swelling, vasodilation, all that stuff because of that T cell response. Notice that this, when you get into some poison ivy, you don't get a rash like 5 minutes later. It's not an immediate type hypersensitivity response. You get a rash a day or so later. And that's because of the time it's taking for the T cells to traffic from the lymph node. Also realize that the first time you get exposed to poison ivy, you're not going to make this response. But the second and subsequent times, this is what's going to happen because you have sensitized Th1 cells in order to induce this response. Yep?
I know some people say that they're not allergic to poison ivy.
Mm-hmm.
Would that just be essentially they haven't been exposed to it yet and they haven't gone through the first phase, or is it possible that they are?
I could imagine maybe there are some MHC types that can't present the right peptides, but my first thought would be a question of how much they've been exposed. Yeah, Mark.
It probably is the MHC type thing. I have a friend who works at like a camp, and they had the same person do the same trick 2 years in a row where they took poison ivy and rubbed it all over their skin, and then the next year did it again, and they
That's sad and tragic. That's not very nice to have someone do that to you.
No, like they do it themselves.
Okay, well,
That's not very nice to do to yourself. Okay. Well, I would guess it would be MHC related as well. I don't know. So there's one other really famous type 4 hypersensitivity response that many of you probably have or will encounter in your life. And this is known as a PPD, which is a test for tuberculosis. So what I'm going to tell you, so the tuberculosis test is administered by a needle. So if you think you've had a tuberculosis shot, it probably was a tuberculosis test. The tuberculosis vaccine is not given in the United States. So you were probably actually getting a tuberculosis test. And when we talk about vaccines, we can talk all about the tuberculosis vaccine and why it's a disaster. But I'm going to talk a little bit about the PPD, how it works, what's going on with the PPD. So PPD stands for Purified Protein Derivative. It is a key antigen from many mycobacteria, particularly Mycobacterium tuberculosis, the causative agent of tuberculosis. When someone gets tuberculosis, they can have active symptoms, sort of the symptoms you think of as tuberculosis in terms of respiratory symptoms. Or they can have a situation where the bacteria is walled off in the lung and sort of kept in check by activated Th1 cells and macrophages. And that was called a granuloma. We talked about that when we talked about Th1 cells. And so in that situation, there'll be sort of a whole bunch of macrophages and T cells all around the bacteria, sort of keeping it from getting out of that one spot in the lung. So you'll have sort of an active immune response. Very likely at some point in the future, that person may lose that control of the tuberculosis and go back to having a sort of more productive infection where they're actually coughing and having the respiratory symptoms that they think about. The moral of this story is that people can be infected with tuberculosis and you don't know, because they might have that bacteria walled off in a granuloma in their lungs. And they might be okay because they are making a Th1 response to that bacteria. So what we need to do in many situations is determine if a person actively has tuberculosis or doesn't. So I don't have any tuberculosis symptoms. So that means one of two things. Either I don't have tuberculosis, or I have tuberculosis hidden in my lungs and my immune system is keeping it in check. And if I was, say, going to be your healthcare professional, you might want to know which of those two things it was. And so if you work in the healthcare system, you actually have to get tuberculosis tests pretty often for exactly that reason. You may also have gotten them for other reasons, but if you're working in healthcare settings, you will be getting these tests. And the way that this test works is based on a delayed type hypersensitivity response. And so what happens is that a little bit of this antigen, PPD, the purified protein derivative, is injected under your skin. You get a little bubble that looks like that. If you do not have tuberculosis, you don't have any Th1 cells responding to it in your lung. And you're not going to make much in the way of a response. And you're going to live happily ever after. If, however, you have tuberculosis in your lungs, you are making an active Th1 response. And when you put this antigen under the skin, some Th1 cells in your body are going to go to that area of the skin and make a response. And so you'll see a response that is both red and raised in about 48, 72 hours. And so what happens is they will put a little bit of this antigen under your skin, and then you go back to have it red 48, 72 hours later to see if you have a red and raised bump. And if you do, that indicates that you have been exposed to tuberculosis in the past. You probably have, you may have it latent in your lung, and you need to sort of undergo more surveillance. And they need to kind of thinking about your interactions with patients. It doesn't mean you can't interact with patients, but they need to be aware. I'll come to your question in a second. If you have, questions in a second. I'm going to finish this part first. If you have a positive response, what do they do? What happens if you're PPD positive? Yeah. Yeah, they give you a chest X-ray if you're positive. So why do we do this? Why don't we just give everyone chest X-rays all the time? Yeah.
One X-ray is going to be harmful, two, this is cheaper.
Yeah. Cost and the amount of radiation dose that you'd be giving people all the time. So one thing I will say, and again, I can talk about this so much more at another point. The tuberculosis vaccine, if you did get the tuberculosis vaccine, it means that you're positive in this for life. And so you can only get chest X-rays. You can't have this simple, easy, fast test. And that's actually one of many reasons why we don't give the tuberculosis vaccine in the United States, is so we can keep our nice, simple, easy test. And so you may likely have had this type of test before for tuberculosis. All right, let's see. Emily first.
So why wouldn't you get a response the second time?
Good question. Is that your question too, Mark? So Emily, yeah, Camilla.
I'm so confused. I had a TB vaccine
Mm-hmm.
when I was like,
Mm-hmm.
that means I will always get that.
So you're PPD positive, yes. Yes. So you might look at this and you might say, but if you get multiple PPDs, then shouldn't you at some point turn PPD positive? And it turns out, if you get many PPDs frequently, say every 6 months for part of your time while you're a grad student, you actually do start to make a response. However, it is not a type 4 hypersensitivity response. It is a slightly different type of immune response. So it tends to be found in people with exactly no melanin. So when I was in grad school and I got a PPD, would get PPDs, I would actually get a response. So it's actually supposed to be a certain number of millimeters around and a certain number of millimeters raised in a circle is a positive response. My entire arm would turn red the whole way. None of it would be raised, and it would be 2 days after this is supposed to happen. So it's a completely different response. But I would have to then convince the doctor, no, that's a negative. That's not a positive, that's a negative, which was super fun. We also realized that the reason why I was getting this response is that what they're trying to do is that when they do the injection is they're injecting subcutaneously. So they're doing the injection under the skin. But when they go into the vial and inject, they get a little bit of liquid on the outside of the needle, and that goes into the skin. It doesn't get under because it's on the outside of the needle, so that's an intradermal. And actually, it was the intradermal that was causing my reaction. So the other thing I could do is I could say to the nurse who was giving me the injection, actually, can you draw it up with one needle and then switch the needles and re-inject me with a sterile needle? And they loved it when I told them how to do their job. So they both resulted in a whole lot of arguments.
Because the same thing happened to me.
Yeah, no, and our lab, so we had people in our lab who were working with mycobacteria, and so we had to be getting them at least every 6 months, and about half the lab started to have that phenotype. Since I have not been getting PPDs as frequently, I think I've only had one since in like the last 10 years. It was not positive the last time I did one, so the spacing it out does make it stop. But yes.
Mine really get like super itchy.
But this much, but like red here and so yeah, I would be like, no, it's supposed to be red and raised. And this is how you're supposed to feel if it's raised. You're like, look, see, not raised. I'm negative. I'm definitely negative. Yeah, they get real mad when you do that. But yeah, Stephanie. It could mean that they were exposed to to mycobacteria or a related mycobacteria, and that their immune system fought it off. Sort of exposure to general similar antigens is probably the best answer. Anyway, so that's what's happening when you're getting the TB test. When thinking about hypersensitivity responses, the other thing to just be aware of is that there are more and more disease states that are sort of in between with autoimmunity and allergy, where we're seeing chronic inflammation playing a key role. And so excess inflammation in any number of cases could potentially also lead to a number of different problems. And so sometimes people are taking some diseases that we used to argue, like, it's an inflammatory disease, or it's an allergy. No, it's autoimmunity. No, it's allergy. No, it's autoimmunity. And we now just call them inflammatory diseases. And sort of try not to worry quite as much about it. Yep, Mark.
Have you seen those like papers and articles that say that depression might be linked to inflammation in the brain?
Yes, and in fact, there was one that came out within the past month, couple weeks about anxiety. That was like a huge paper. Yes, there are such papers. I think that there's a lot mechanistically that's unclear, but yes, there have been a few that have come out. However, the example I'm going to tell you about is not that. So the one sort of classic example of the disease everybody has argued about is celiac disease. In celiac disease, individuals eat gluten, and the gluten is degraded to make a particular peptide. And so you can see the bread turns into the peptide as a result of digestion. That peptide can enter into into the GI tract and be acted on further by other enzymes. And then you get this deaminated version of gluten. We can then have T cells start to make a response to this deaminated version of gluten and have T cells start to destroy the GI tract. Eventually, particularly the cytokines are really going to cause a lot of problems with the GI tract. And so instead of having all this nice surface area for absorption in the GI tract, we see that the jejunum wall, the small intestine wall, looks something more like this. And what you can see is that it's hard to say, is this allergy? Because I'm not bread. That's questionable. But a self-enzyme is important. And so this is one where people have now started to say, okay, I think this is really an excess inflammation problem and an inflammatory disease, more so than trying to argue about exactly what we're going to call this antigen. And the reason why I mention this here is that for the rest of the time today, I'm going to talk about different therapies that are used for allergies and autoimmune diseases. And those therapies that can be used for allergy or autoimmune disease tends to be pretty similar. And we, in fact, see similar types of therapies that are being used for these chronic inflammatory diseases. And so this group of therapies that we're going to see kind of hits for a few of the disease states that we've been talking about so far. And so if you have allergies, there are a few different types of meds that you might be treated with. I'm really only going to mention 2.5 on this, that are actually on this slide. So one of them is an antihistamine. And with an antihistamine, you are blocking histamine receptors so that the histamine can be made, but you will not have the physiologic response to histamine. And that is what we see in a lot of kind of the baseline standard over-the-counter allergy meds. We can also see a Adrenaline, also known as epinephrine, being used particularly for acute things like anaphylactic shock. This is the EpiPen. Here we are specifically altering a receptor on mast cells to stop mast cells from being able to degranulate. So we're blocking the beta-adrenergic receptor. We're binding beta-adrenergic, we're stimulating cGAMP, and we are preventing mast cell degranulation. Prevented if cAMP levels remain high. Yeah?
So the beta-adrenergic receptor is the receptor that makes mast cells degranulate?
So there are lots of receptors that make mast cells degranulate. The moral of the story is if cAMP levels in the mast cells get messed up, then mast cell degranulation gets messed up. And so really what we're doing is we're trying to mess with the cAMP, even though that's not the primary receptor for the mast cell. Okay? Yeah. Yep. Yep.
How does that sort of activation work? That like if cAMP levels rise transiently, degranulation occurs, but if it remains high, it doesn't.
It's sort of our same Goldilocks problem that we've seen again and again, where excess signal is going to lead to negative signal responses because of sort of high signal levels have a detrimental effect. It's the same old Goldilocks that we've just seen over and over. The other thing that you can see here is cortisone, which is a steroid. And you can see that it reduces histamine levels by blocking histamine production, as well as leading to, again, degranulation release. But in reality, when we look at many of the steroids that are used for allergy treatment, they have multiple effects on the immune response. And so most corticosteroids do impact immune cells. We saw this a little bit when we talked last time about male and female immune responses, and we talked about how hormones might be playing a role in male versus female immune responses. Other steroids can also influence immune responses, and so you can see that there is reduction in inflammatory cytokines, changes in some of the things that are made by mast cells, changes in adhesion molecules. There's a lot going on here. It's not just one effect of those steroids. And this does not even get into things like T-cell suppression, which also will happen as a result of some of these steroids. In the middle, you can see prednisone, which is one of the major steroids that's used for people who are having allergic reactions in the clinic, which is quite similar to hydrocortisone. And so in the end, steroid treatment looks something like this. We'll have some steroid. It's able to diffuse directly across the membrane to its receptor and ultimately change transcription. And there's so many changes that it can make. This list that is in this table is by far a minor one of those, a minor list. The other thing to mention is that particularly for some of the allergies, we can see the use of immunotherapy, which is generally referred to in this case as desensitization therapy. This is where you get your allergy shots. As a way to reduce allergy symptoms. And so here we are giving versions of allergens, in many cases orally, to try to induce a Treg type of response and try to deviate a previously Th2 or something else response into a Treg response to turn off the response. As I mentioned last time, this has been extremely successful for kids with allergies to peanuts, who couldn't even be in a room with peanuts before, who can now at least sort of go out in the world and not be as worried. Yep.
So how come this doesn't work as well with
that would require us to have a better idea of the details of it working in the first place. Good question. Yeah.
Has there ever been a case where, like, a child with severe peanut allergies, like, they can't even be around it, like, is completely okay after?
I don't know that none of those kids are eating peanut butter sandwiches, but they're able to kind of live in the world. Yeah, is really kind of where the cutoff has been. I think people who started out with a less severe allergy have gone down to maybe to peanut butter sandwiches, but the people who had the real problem are those kids who, like, if anyone in this room had a peanut, yeah, those are the ones where we're really particularly worried. So a lot of the other treatments that we're going to talk about are officially autoimmunity treatments, although they could be used for allergies, they could be used for a number of different things. You can see that they can go into a few different categories in terms of whether they're hitting trafficking or signaling or things like that. And so I'm going to kind of break these down into a couple of groups. The most famous one of all of these, the therapy that kind of made all of this possible, is called Cyclosporine A. And I've told you a bit about Cyclosporine A when we talked about signaling. Cyclosporine A, and there is a similar compound called tacrolimus or FK506. In my mind, they're basically the same thing. Both of these products work to inhibit calcineurin so that we have the calcium signaling that happens downstream of IP3 in our T cells. Calmodulin gets activated. Ideally, we're going to activate calcineurin. We're going to dephosphorylate NFAT and let NFAT into the nucleus to do transcription, make IL-2, turn our T cell on. If we treat a patient with cyclosporine A, you can see that cyclosporine A, which is this orange guy, gets in the way of calmodulin, calcineurin signaling. So even though the calcium is there, it binds calmodulin. We can't go any further with the signaling. Cyclosporine A has blocked it. So NFAT never gets dephosphorylated. NFAT never goes into the nucleus. As you will see when we talk about transplantation on Wednesday, this basically is the drug that made modern transplantation possible. It revolutionized the transplant industry. It is also used in a number of different autoimmune diseases for treatment. The idea being that T cells are too active, and so we're going to reduce T cell activity with this drug. But if you look at this information, you also might realize a problem that you could imagine with cyclosporine A. This is somewhat true with the corticosteroids we were looking at before as well. And so what's the problem with cyclosporine? Yeah?
There's multiple ways to activate T cells.
Okay. So this isn't the only pathway, but there's sort of another place where it becomes problematic. Yeah? Yeah. It's not like you're giving cyclosporine just to the T cells that are killing the transplant or just to the T cells that are autoimmune. You're disrupting all the T cells in the body. You are basically taking your patient and broadly immunosuppressing them. And so your patient now is not going to have their autoimmune symptoms, but they are also going to be susceptible to a number of other disease states. And so one of the problems, and this is a problem in a lot of different sort of areas of medicine, is that in some cases we have some pretty awesome meds, but they're really broad. Like this one's really broad. It hits all the T cells, not just the bad T cells. And so what we would like is we'd like to figure out ways to be a little more specific, to sort of narrow down what we're hitting here. Notice, transplantation in particular would not exist without cyclosporine. Cyclosporine is a miracle drug for many people. But as we think about sort of being scientists of the future, we can imagine places where things like this may need to be improved. And so the big area that people have moved into is in the production of molecules called biologics. And so this is one of so many of the biologics that are out there. So this is one called rituximab, which can be used for rheumatoid arthritis. Rituximab is an antibody against a protein on the surface of B cells. It's on the surface of mature B cells. And so we can treat with this antibody, and those B cells that are making the rheumatoid factor antibody can get killed. So we can kill off sort of mature B cells. Good news is we haven't hit the immature B cells. So once this drug goes away, they can live a normal, happy B cell life. And we're just going to kill the mature B cells. So this seems a little bit better. Similarly, we can use things like abatacept or Orencia, which is a protein that has the CTLA4 binding region. So it will actually get in the way of T cell activation. It will make it so that the CD28, CD80 interaction can't happen. So T cells can't get turned on. And again, this is used in huge numbers of autoimmune diseases to stop the T cells getting turned on. With this one in particular, we can go back to what Emily said and say, well, there's multiple ways of turning on or off a T cell, so maybe this isn't quite as detrimental. We're hitting one negative signaler, but there's some other ones, so maybe this will be okay. And here you can see exactly how that worked. You've got CTLA4. It is engineered so that it actually has part of the antibody heavy chain. It's not just CTLA4 by itself. Normally our T cells get turned on. This molecule, however, binds to B7 so that our T cell can never get turned on, and we're energizing our T cells. And so again, this is a little bit more specific. But the other really big thing that people are doing are the cytokine-based therapies. And there are tons. This is from your textbook, and I would say that this is a dramatically out of date and not detailed slide. So we have things like Enbrel, Remicade, and Humira, which are all active against TNF-alpha. There's one beta-seron that's active against interferon beta. There's one anakinra that's active against IL-1. And the idea with all of these is that normally TNF binds to the TNF receptor, but we can use some antibody. There are a few different ones that bind to TNF that basically neutralize the TNF so that there is no TNF to bind to the TNF receptor. And so this T cell no longer gets, or this cell no longer gets its inflammatory signal. We don't see the inflammation effect of the TNF. There are other examples where we can either have the cytokine get all bound up, or there are some where the antibody binds to the receptor so that you can never get signaling between the cytokine and the receptor. And there are tons of these, as you can see. So one big picture thing about them is sort of shown here. The anti-TNF drugs were first described and first used for rheumatoid arthritis. And so these data are some rheumatoid arthritis data. So you can see that people who were treated with placebo had a whole lot of this protein, C-reactive protein, in their blood. That's a marker of rheumatoid arthritis. You can see that when they were treated with an antibody against TNF-alpha, it goes away. We can see that if we look at swollen joints, they have a lot of swollen joints. When they have the anti-TNF-alpha, they don't have swollen joints anymore. When we look at how much pain they have, the drug also blocks the pain. These drugs were revolutionary and life-changing for many of these patients. My dad was originally on one of these drugs for an autoimmune disease he had. He had psoriasis, where he had a huge percentage of his skin covered in lesions. I can't remember what his percent was, but we'll say 50. It was a lot. when he started these drugs, within a month he had 0%. I mean, and his psoriatic arthritis was gone. Like these drugs are amazing. So what can we say about what we see going on with these drugs compared to cyclosporine? What are sort of pros and cons you might imagine? Yep.
It's more targeted area, so that it's not affecting all T cells and shutting them all off. Instead, it's going after specific ones.
Okay. So yeah, the key thing here is that we've gotten some narrowing in. Now we're not quite hitting all the T cells. We're hitting slightly fewer of those cells. And so we're getting some specificity. It's still not perfect. We still are going to see lots of situations where our patient is going to be somewhat immunosuppressed, but they are a bit less immunosuppressed because now they're losing one cytokine instead of one whole T cell subset. But as a result,
I've been fortunate to win on golf's biggest stages, but when joint pain and stiffness from psoriatic arthritis hit, even the smallest things became difficult. I finally understood what serious joint pain is like. I talked to my rheumatologist, and he prescribed Enbrel.
Enbrel can help relieve pain, stiffness, and stop joint damage. Because Enbrel, etanercept, suppresses your immune system, it may lower your ability to fight infections. Serious, sometimes fatal events including infections, tuberculosis, lymphoma, other cancers, and nervous system and blood disorders have occurred. Before starting Enbrel, your doctor should test you for tuberculosis and discuss whether you've been to a region where certain fungal infections are common. Don't start Enbrel if you have an infection like the flu. Tell your doctor if you're prone to infections, have cuts or sores, have had hepatitis B, have been treated for heart failure, or if while on Enbrel you experience persistent fever, bruising, bleeding, or paleness.
Get back to the things that matter most. Ask your rheumatologist if Enbrel is right for you.
Enbrel, the #1 biologic medicine prescribed by rheumatologists.
so why was there all of that? If you have this symptom, call your doctor. If you have this symptom, call your doctor. Why was there all of that stuff at the end? Why do we have to hear all of that about side effects at the end of this commercial? Yeah, we are immunosuppressing our patients. And sort of we have this great thing where we're able to really, really, really help our patients, but we also have this potential problem that there are probably more people in the world who are immunosuppressed right now than there might have been in the past. And so we can kind of think about what that means in a variety of reasons. And so this is sort of the pros and the cons. And so for a lot of patients, this has opened up quite a bit for them and has been wonderful. My dad is no longer on Enbrel. There are two reasons why my dad is no longer on Enbrel. One, his doctor told him that it's a good idea when you're on one of these drugs to switch every few years. Why do you think? And I was at first like, but the more I thought about it, I can see a reason why it might be a good idea to switch every few years. Why might you imagine it could be a good idea to switch? Yeah.
Could it have something to do with in varying the place where the response is blocked? That no.
No. Yeah, Mark.
Is it because depending on the drug, you would be blocking different cytokines, which means that you would have like the ability to respond kind of to
Nope.
different
No. Nope. What are we injecting you with? What are antibodies?
Oh, the form.
Yeah, so antibodies are proteins. There are different ways of setting them up to see how foreign they are. There are some cool ways people are now making fully human antibodies in the lab, and so they're fully humanized. But the idea would be that after a certain amount of time, it may stop working for you because you may start making.
So it looks like the audio batteries died at this point in the lecture. So I'm re-recording the ending over the slides right now. Fortunately, I was almost done with this slide, and it is the second to last slide. And the take-home message is that antibody drugs that block cytokines like TNF-alpha drugs that can block the TNF-alpha, as is shown here for rheumatoid arthritis patients, can be a very useful drug that has been an important addition for many patients to their clinical treatments, and that has been incredibly helpful for those patients. In a second, we're going to switch to the next slide. So these drugs have made huge amounts of money for many companies and have been very useful. This slide shows an overview of all of the different types of immunotherapy that are now available. What you can see is that there are molecules that block signal 1, like an antibody against CD3. There are things that block signal 2, like those antibodies that can block the B7 CD28 interaction. There are some that will deplete particular cells. There are some that block cytokines, so that's signal 3. There are also things like cyclosporine that can block the intracellular signaling of cells, particularly that's a signal 1 blockade as well. And so largely any part of the T cell activation pathway that we've learned about can be blocked by some drug for immunotherapy. Again, this is going to be more specific than some of the very broad drugs that we've talked about before, but it still is going to be affecting more than just the autoimmune or allergy inducing T cells and will be broadly immunosuppressing our patients.